Okay, so welcome back to the ARMA conference afternoon session. And I'm now going to introduce the chair for our third session, Sanjeev Patel. Sanjeev is a consultant rheumatologist, and he's also president of the British Rheumatology Society. So I'm really pleased that he's agreed to chair one of the sessions at today's conference. Over to you, Sanjeev.
Well, thanks very much, Sue. I hope you can all hear me clearly. It's my real pleasure to chair this meeting where we're going to be discussing working across boundaries. This is really critical because patients and the patient journey don't respect boundaries. And as clinicians, we recognize the interfaces, but breaking these interfaces can be only good for patient care. We've got a packed session, so I'm going to start immediately by introducing Lynsey Hetherington. She's an extended scope practitioner and podiatrist at the North Tees and Hartlepool NHS Trust. So over to you, Lynsey.
Thanks, Sanjeev, and thank you to Sue and the team at ARMA for inviting me today. I work in North Tees and Hartlepool Foundation Trust as an extended scope musculoskeletal podiatrist, as well as the integrated musculoskeletal service lead. And I'm also a musculoskeletal champion for Versus Arthritis and an ambassador for them. And I'd like today to share the story with you of how our musculoskeletal service and rheumatology services have successfully collaborated and built a strong relationship to work across the pathways for our patient. Our regional ICS, the Northeast and Cumbria, got together a few years ago to review the provision of rheumatology services in our patch. And it was widely recognised that there's a significant shortfall in the workforce to provide the rheumatology service to the capacity that it's really required. We're short on rheumatology consultants, and unfortunately, as you'll be aware, there's no magic wand to bring those consultants to us. So we were challenged to think about how we could work differently to provide the capacity within the workforce and to better serve the patients that really need our services. And the ICS established, amongst many other issues, that patients do want to be seen closer to home. They want to have more appointments, better access whenever they really do need it, but also that they want to have fewer, maybe unnecessary appointments cropping up within their day-to-day lives. So the challenge was set. How can we collaborate? How can we do things differently with limited, if any, additional resources to try to provide that for our patients? How can we ensure that we do that without diminishing what we give to the patients, what we provide for them, and if possible, actually improving on the service provision that we have without more consultants, without more rheumatology nurses? What have we got already within our resources that we can reutilize, that we can reframe and repurpose to make that provision? We were really privileged that our trust dedicated 2 days of coaching to this project, and they set us a 90-day challenge period. And they also dedicated a further 2.5 days worth of coaching sessions within that 90-day period so that we could work through the project towards our launch date and our launch event. We worked with a company called Think On, and some of you may have come across some of the Think On's workshops, Go Mad Thinking, which kind of gives you a flavour of how the tone was set from the moment we entered the room on day one of our project. So we started in March 2020, and we were facilitated by the Think On team, and it was fantastic to have their input into coaching us through the project. And also they were able to provide impartial and unbiased facilitation to the project as we worked through it, which is something that we don't often get the opportunity to do in our NHS hubs. So the project team consisted of our rheumatology consultants, our physiotherapy lead consultant, the rheumatology nurses, the musculoskeletal physiotherapists and our core physiotherapy team, and our musculoskeletal podiatrists. We included our outpatients transformation lead, and quite critically, we included our musculoskeletal and our rheumatology administrators to make sure that we weren't dreaming up all these wonderful processes that were really too far beyond reality to be effective and purposeful. So with the coaching that Thinking On led, we were asked to think of new ways about how the team can deliver the project, new ways of thinking, and we used a number of tools. I'm going to guide you through a little bit of detail around some of those tools because they were really useful to us. And that the first one is hindering self-talk. And we all on a day-to-day basis have huge amounts of uncertainty. We know that we've got worries and concerns and problems, and a lot of that is related to change. And it's how we can look at that talk we have with ourselves and try to reframe those concerns as opportunities, reframe things as benefits and challenges. And we need to look at the situation for ourselves, for others, and the situation as a whole. So we look at potentially reframing the situation that we're walking into. So for me, on the first day of the project, walking into to work alongside the rheumatology team, my instant reaction is, oh goodness, they're the rheumatology team, they know so much more than me. So the challenge I was given was to reframe that thought as not that they're better than me, but that they can help me in this process. They can help me rather than me feeling that I'm less than they are. And also how we recall things that have happened historically and the experiences that obviously lend to the choices we make. And a really simple one is, reframing an embarrassing situation as maybe as an exciting situation. And then we looked at how we imagine our futures. And I think never more so has that been a real challenge to the NHS. So we started this back in March 2020, and at that point we were challenged with reframing the thought of things are going to go wrong to how things can be pleasant and positive outcomes can occur. And then that's pretty crucial at the moment. And this Thinking Effectively model really opened up the ground for the project team to have some really useful discussions. And then we went on to a 20 solutions to one problem scenario. We were given a set time frame of about 5 minutes where each of us individually had to write down 20 solutions to the one problem. And in sharing those quite rapidly developed solutions, we learned a lot about each other. We learned a lot about our take on the vision that we had. We've all got the end goal of trying to make things better for the patient, but the way we approach that very differently, particularly with our connector types as well, has a massive influence on that. And then we pulled all that together using the Think On Results framework, which helped us to establish how we were going to progress the project through in a 90-day framework, a 90-day period. And the points that we used within that framework were the reason why we were doing the project, and we defined the project. So for us in defining that project, we were looking at developing a single point of access for all of our patients accessing the rheumatology and musculoskeletal services. We looked at the possibilities around that. We looked at the priorities around that. And we looked at our self-belief as a team within the NHS, as a musculoskeletal service and as a rheumatology service, our belief that we actually could achieve this within 90 days. and also our personal responsibility. We involved others, and we also ensured that we had the drive to take action and to measure the outcomes of the project as it ran, and as we see the extent of the success from the project. Through using the framework from Think On, we were able to garner strength and importance into the project. So not just importance for the project team, but actually we were able to start to pull out why this was so important to the trust and why it was so important to our patients. We were also able to use the framework to ensure that we were making sure our tasks were ticking over, that we knew what our tasks were, and that we had buy-in from the whole project team and further afield to achieve the goal of the project. Achievability is something that we were able to pull apart and put back together throughout all elements of the coaching sessions. And we put checks in place so that we know if we complete a certain task, we can check the detail, we can check we've done what we need to do. And if we get to that checkpoint and things don't look how we want them to look, we've got choices to work from there. And we've been able to use that quite effectively more recently, getting to a checkpoint and realizing things aren't quite what we had hoped they were, but then having choices as to how we can correct or move forward or review where we're at. And that really is one of the critical things of the coaching sessions, has been to offer us up all of that richness of information that we share amongst ourselves in the project team across rheumatology and musculoskeletal service with joint understanding. And then we started to use umbrellas. So we knew that our StatSPA single point of access was going to be our overarching umbrella, underneath which we had a number of smaller umbrella type projects, including digitalization, patient self-referral, education, experience, co-working, and just there was numerous other little bits and pieces that we managed to pull out through the coaching experience. And then at that point, we headed into wave 1 of COVID-19. We extended our 90-day challenge to a 180-day challenge. We took our coaching sessions onto virtual meeting platforms, and we reimagined our launch event as a webinar that we could share with GPs. But COVID also presented us with an opportunity to build on one of the most key and tricky aspects of building relationships between teams, which is trust. So the credibility, the intimacy and the reliability of a team against that self-orientation of a team. How can we get the teams to trust each other? And we were able to redeploy a musculoskeletal physiotherapist and a musculoskeletal podiatrist into the rheumatology teams to help them with the triaging of their shielding patients and providing some hotline advice to patients right at the very start of the first wave. And it gave us an opportunity to explore our knowledge of the other professions that we work with. You know, how do we get that credibility between us and other professionals? So I challenge you, do you know really the detail of what other professionals that you work with? How do you know that they're credible professionals? For example, did you know that a musculoskeletal podiatrist can undertake ABPIs, vascular assessments, local anaesthetic lower limb blocks, minor surgery with tourniquets? They can assess and manage and recognise the signs of infection in peripherally ulcerated immunosuppressed patients, alongside assessing hips and the impact of muscle balance in the hip on posterior tibial tendon dysfunction, prescribing medication. And of course, we cut toenails and do callus and corns. So being able to work alongside the rheumatology nurses, the rheumatologists, and the physiotherapists and podiatrists together, and to help educate each other in practice and to observe each other, it really, really led the rheumatology team to have a much greater understanding of what our professional remit and the extent of our professional remit is, and therefore gave us some credibility in their eyes. And that was a massive step for us. And as I say, it's one of the positives that COVID did bring to us. From an intimacy point of view, obviously, the opportunity to work in the same room, in the same staff room, in the same area as these teams, to build face-to-face relationships, to get to know the staff that you're working with and that you're co-managing patients alongside, is really, really beautiful in this scenario. And the reliability, which has been a real huge challenge for us. So what we try to do from a reliability point of view is be reliable in our fairness and our openness whenever we're responding to queries from each other. So we try to respond to emails as quickly as we can, but also that we know we can give a really fair judgment, a really fair opinion on what's going on, and that there's no difficult communications, there's a better understanding of the behaviours behind each clinical member of the team, and therefore we have that reliability in our fairness and our openness. And then self-orientation, being able to, as a musculoskeletal team, say, we've got to be a little bit selfless here. We want to give you something that we know is going to help you, and that is our clinical time. Here are some of our clinicians to sit in your clinics, to undertake your NMP injections, to help assess those patients that maybe don't really need to see the rheumatologist and would be better served with a physiotherapist. But here's our time. We don't need anything back. All we ask for is that reliability whenever you are responding to our queries, whenever we need your help. If we phone you, can we rely on you to get back to us? And that's really as simple as it's been for us to build the trust between the services. And in building that trust, we can now have really open and really importantly, really low effort discussions between the teams. There's no barriers there anymore. And that leaves us personally with the energy to put the effort into the patients that we want to serve. And we can bring those musculoskeletal patients out into the community where they want to be seen. We know that's where they want to be seen, and they can be seen by physiotherapists who need to see them, therefore opening up those appointments with the rheumatologist for patients who really, really, really need to be seen by the rheumatologist. So thank you very much for your time this afternoon.
Well, Lynsey, thank you very much. That was a really important and a detailed account of your change. And can I just ask you, this seems to me more about bringing the team together within organizations which are quite siloed, which is one of my big bugbears at the moment. And could you say a little bit more about, was this sort of internal facing as opposed to external facing with patients in primary care? Because there's a couple of questions I'll ask in a minute, but just to clarify, was this about bringing people together in big organizations so that they can develop that trust, they can have that support to manage and help patient concerns and queries?
Absolutely, it was about breaking down the silo between the teams inwardly, so that as a bigger and more robust group, we could then significantly advance the offer we had, looking outwardly to the PCNs and to the patients, but actually being able to come together internally in the first place to do that as a team.
Great. And how did that impact on the service to patients? And at which point did you engage with patients and users of your service, both with regards to this project, but also perhaps some of the changes and benefits that you think have accrued from this?
So with regards to within our stakeholders, probably the most obvious people that we missed out in the project team were the GPs and the patients. we know that prior to the project, the ICS had done a huge amount of work involving patients, so we lent quite heavily on some of that information. And then we were pulling that through now into some later stages of a couple of pathways that we're working on, and we've got some patient involvement, particularly around our self-referral work. And I think the lack of having the GPs included in the project is probably been one of our biggest stumbling blocks, which is why we've developed a webinar to share with them. And we're still hearing back from the GPs. And the great thing about the coaching tools that we used, I talked about the checkpoints, and this is something that comes up at our checkpoints, and we're now looking at the choices we have to pick up some difficulties we have with some GP connections. We know that we've reduced the referrals into the rheumatology department by a third, which for us as a musculoskeletal service, we have about 1,500 referrals a month. The rheumatology department has about 200 referrals a month. So it's quite a small number for the MSK service to absorb, but it's quite a large amount for the rheumatology department to be able to have that pressure released from them.
And where do you see this project going forward? Because after the team has been built, one of the concerns that's coming up on the chat is engagement with patients and service users and primary care. Do you think you feel now more confident that you've done the, if you like, the inward looking change to now then present yourself for a little bit more scrutiny externally, and then to develop the process and the service in an iterative way going forward? Can you say a few words about that?
Absolutely. We're confident with our inward processes now, but we really have lacked some of the patient engagement, and that's something that we are absolutely looking towards. We are starting to embrace some feedback questionnaires from patients, and with the advent of COVID, QR code scanning has been a big boon to us. We're able to use that a lot more to connect with patients in a way and get feedback from patients that we've never had before. And we're really keen to find out how that's working and how the patients feel presenting to the musculoskeletal service rather than the rheumatology service, if they feel they're being better served. We have gone live with a community pain management pathway, so we're able to link patients with persistent pain into that pathway as well. At the moment, it's been a busy period for us, so we've got a lot happening, and that we do really need to look at the data and also the patient feedback about the smoothness of them getting to the place that's providing them with what they need what they want and what they need as a patient.
Okay, great. So I hope that's answered the patient questions raised by Lynn and Rachel. David and Alderson asked about primary care, and that engagement is ongoing. Sally Pembury's asked about fear in triaging patients, that people with certain conditions and pain levels get missed and never see the rheumatologist or are delayed in seeing them. So do you think there's a step there which is there, but do you think you've reduced that step by the trust and the communication you now have directly with rheumatologists?
Yes, since we've gone live, despite doing a lot of pre-work into our triage criteria, in week 1 alone, we probably reviewed our triage criteria 3 or 4 times with different cases. We're constantly reviewing that, and having the connection team and knowing that they're at the end of the phone if we need them has been really critical to making sure patients don't slip through the net. Also, we're aware that GPs often contact the rheumatologist for some advice on managing rheumatology patients prior to their arrival at a rheumatology appointment. We've been really, really careful that that information isn't lost when the triage comes through the musculoskeletal service. We want to make sure that nothing's lost from the patients on that front. It's not something they should be giving up at all.
Okay, great. Look, I'm going to stop there now. Lynsey, well done. That was really, really clear, and I think really exciting about how change can be achieved within trusts and between teams to bring them closer together. I want to move to Carl Davies now, who's Director of MSK at the Berkshire West Integrated at the ICP. And Carl is a physiotherapist by clinical training, but has a huge amount of experience in changing complex organizations. So I'm looking forward to hearing of Carl's contribution to today's discussion about working across boundaries. Over to you, Carl.
Thanks, Sanjeev, and thanks to Sue for the invite today. I'll just start with an apology because I'm actually in the process of moving house, and so I lost my internet connection earlier this morning. And so I've arrived at a friend's house, a good friend of mine, who's let me use his internet for work purposes. And I'm in a small office out the back, essentially. And he thought it'd be hilarious to let me use a My Little Pony mug for this conference, for the purpose of this conference. So I'm here now just trying to make sure that we've got the tools and the means to get through the presentation. I'm hoping the internet connection here will work. I'm out the back, like I say, so I'll do my best to make sure that it stays with you, essentially. So I'm just going to share my presentation this time, slightly different to Lynsey, so I hope you can see this now. And so just to start, firstly, as Sanjeev said, I'm Carl Davies. I'm Director of MSK at Berkshire West ICP, and the role is quite different to roles that normally exist in that I'm formally employed by lots of different organisations, specifically to work on behalf of the patient and with patients across the system, and to try and change the direction of how we make decisions for all of those services that sit under MSK or for orthopaedics, and start to actually think about how we deliver change across those systems. And as Sanjeev alluded to, I was a physio by background a long time ago now, probably 10 years ago now, at least 7 or 8 years ago. And one thing that plagued me all the way through my clinical career was, why was it that when so much is known, from the evidence base, from the things that patients tell us, from the things that clinicians know themselves, from the things that management know themselves about what the solutions should be and the things that we should be doing, why is it that the systems are so slow to change? And fundamentally, that question sort of plagued me, and that the answer was that it's extremely complex. So it kind of brought me towards complex systems, and I've been studying that now for sort of 10 years, and I'm in the middle of a PhD to look specifically at that. And so what I want to do is just share with you some of the things that we're doing in Berkshire West. But before I do it, just a nod to some of the people informing this work. Donella Meadows and Russell Ackoff, big complex systems thinkers. Their work is fantastic for anyone who hasn't read it. Professor Donna Hall, the Wigan Deal, and again, great piece of work up in Wigan around how do we connect with service users, patients, community members, and how do we build social contracts. There's a two-way engagement and involvement process there. Toby Lowe's work on human learning systems, which is fantastic, around how we move away from that traditional outcome-based performance measurement models towards one that's built around collaboration and trust. And Bev and Etienne Wenger Trainer, system conveners, around how we actually lead across systems and do the more complex leadership roles. And I've been lucky enough to be involved and have many of these as parts of the partners that work with us on this system. So the key principles of what we want to do is move away from the stereotypical contractual management approach, where we're making decisions in a silo, completely removed from the people it affects, and actually engage and put the power in the hands of the patients and the clinicians. And that means around engaging and involving them in all of the decisions that take place across the system. And one thing I should just say before I go any further is that this is the start of a process for me. We're probably looking at a 3-year process, and we're really in the kind of involvement and early phase of it. And I think COVID obviously changes an awful lot, and we'll see how that plays out. And what I'm going to share with you today was perhaps what we kind of imagined just before COVID hit. But that there's a focus on collaboration, that we're going to reduce the need for high numbers of KPIs, key performance indicators that would normally be a kind of distant proxy measure for care, and actually start to think about how do we get really good narrative and learning from patients themselves that will actually help direct decision making across the system. How do we build trust, and how do we make sure we engage people to allow that trust to build, and then how do we form social contracts in order to deliver on those agreements and that trust and those relationships that we build. So just to say, before I start, there's a lot of talk around systems, and I just wanted to give a definition in that it's a complex set of elements that's coherently organized in a way that achieves something, so has a functional purpose. And that purpose can be quite subjective. And there's a saying in cybernetics that the purpose of a system is what it does. And there is little value in us sort of giving our own view on what the purpose of a system is, if actually what it's delivering is something entirely different. And this comes back to why it's so important that the patients are such a loud voice in driving the decision making within the system. If we as clinicians or managers or strategic decision makers think a system is delivering one thing, but patients themselves are telling us something completely different, then the purpose of the system is what it's currently delivering, not what we think it might be. And so just a few, there's obviously lots of principles and properties behind complex systems, but four that I always think are really important is that we have to recognize that they're emergent. There's no one person that directs it. We don't often get the opportunity to design from scratch at the start. We're kind of trying to rebuild, that kind of analogy of rebuilding a plane whilst we're flying is increasingly more apparent. And we need to remember that these will merge and evolve over time, and often in a non-linear way. Well, absolutely in a non-linear way. So some of the effects that we think we'll have when we introduce a change might well have a series of unintended consequences that destabilize or suboptimize the system in a way that we hadn't anticipated. So starting to engage widely, involve widely with the people that use the services, with the people that deliver the services, really, really important. And that, although they're non-linear, although they're quite difficult to predict, they're not totally random. So they are path dependent. So what we tend to see is this knock-on effect that starts to shape it over time, which is why change tends to be slow. And then finally, that there is no official boundary. So when we look at any system, we essentially see that the boundary of a system is subjective. So whether we take that as an individual, a service, an organization, a health and social care system, a national level system, we're all systems within systems within systems, and all of those boundaries really are subjective and difficult to define. But having an attempt to say what is the scope of your boundary that you're going to work within is really important, so you can make sure you include the right people. And then one specific thing that's really, really important, it's really good to see Lynsey's presentation that similar themes came out about the importance of that connectivity and interaction. And really it's how the and is the multiplier. The and is the thing that really starts to create value. When we start to build those relationships and start to work together, we actually remove the tendency to become disjointed or competitive in some instances, and actually start to multiply the impact for patients and actually start to work together so that the patient doesn't essentially feel that kind of disjointed effect of services being delivered across the system. And so one of the things that the organisations did before, so they spent about 3 years connecting with the current services and patients and actually starting to talk with them about what this should look like and how we can kind of reimagine services for the future. And this was done before I came in, and essentially, as is always the case, that we would get to the complex discussion around how we actually fundamentally change those services. And they came up with a few projects that essentially needed a large investment, and there was an assumption that they would be enough to actually deliver the improvements that the patients had identified were important to them. And that kind of started just as I joined. And what I felt we needed to do was actually go bigger than that and actually start to think about how we connect more people to this, how we engage and involve more groups of stakeholders in this piece of work, and actually how we think about mitigating some of those risks and making sure that we can deliver on the outcomes that we set out to deliver for those patients. And so I'm not going to talk through this, but you'll see that the programme itself now is extended to include lots of different stakeholders, and some of these are led by patients themselves. We have a patient reference group that will be part of helping shape some of the conversation around this. Some of these are things around policy and process that we think serves a purpose, but ultimately doesn't work for the interest of the patients, so we need to challenge them. And although it has an impact and it is an important part of the governance and control, we need to perhaps think about ways that we can deliver those differently. And part of that, as I said, is about how do we draw the boundaries around the services that we're going to include. And so what we're trying to do, and this is a work in process, and this is what I want to get as a key message, is this is an iterative process that will remain live for the next 3 years and will probably be ever changing. This has already changed twice in the recent, probably 6 months. But ultimately, you'll see that the clinical services in blue are the ones that we start to think, how do we define ourselves as an MSK and orthopaedic system? We've got pain services, orthopaedic services, we've got community services, rehab and core physio, and we've got our primary care services. But actually, how do we go beyond that and think about the other partners that we can connect with? And this partnership will continue to grow and involve more and more organisations and people. And so we've got social prescribing, we've got arthritis, weight loss services, local exercise and community groups, Age UK and other voluntary care organisations, Get Berkshire Active. ARMA will be part of those conversations and has been to the past. And so how do we start to broaden this out so that any part of those services that interact with other services supporting patients with MSK and orthopaedic conditions, how do we make sure we're building that as a partnership? And actually, how do we start to build them on some really strong foundations from the start? And now, there's been already some questions around patient involvement and the importance of the patient voice. And for me, it's got to be extremely loud, and that needs to remain a fundamental part of everything that we do and every conversation that we have. So patient-centered, all systems, change, processes, procedures, all need to be built around the needs of the patient. And as I say, when you look at a lot of the processes and the systems that we build, they can work for one partner. So they might be really good for the service in terms of managing referrals. They might be really good for governance of activity and making sure that we're delivering high value procedures, but actually it might not work for the patient. And so we need a place, and we need the opportunity to go and challenge and ask that question, where does this really work for patients? And as part of that, we need to make sure we're capturing PROMs and PREMs, so outcome measures and experience measures. And actually they need to be a fundamental part of what we do and inform decision making. So quite often PROMs and PREMs are captured at service level, but not ever really seen in terms of informing decisions across the system. And so what we're trying to do is make sure that we actually use that as a key part of helping shape decision making, so that we get some really good feedback. And there's also going to be a feedback tool which will be live for any patients to give us some feedback around what's not working well, and what needs to change, and what views could we actually go to consultation on to actually think about doing differently. And then self-management, we talk about self-management a lot, but what does that really mean? How are we going to empower people with that? What do patients want? What should that look like? And how do we design that? And how do we make that digitally enabled for those patients that want that? So how do we start to invest in digitally enabled technology that supports patients with self-management, that gives them really good evidence-based interventions and support? And how do we support our workforce with delivering that? So that's sort of in a nutshell, sort of the vision as it currently stands, but it will continue to evolve over time. And so what we've come out with at the moment in the next phase is that we need a kind of brand and a website to actually build this partnership. And we need a central place that we can all kind of get a coherent message and join up that kind of message around working together, collaboration and supporting patients. And that will house some of the key services and offers for patients. Embedding PROMs and PREMs, supported tech, as I've alluded to, improving access and governance, and thinking about how we can sort of radically redesign some of those processes around the patient and properly wrap them around the patient, how we can deliver condition-specific pathways, how we expand our current services that we've looked at, and perhaps revise some of those models, how we can have supportive patient expert services and what that should look like. So there's a real need for me to have that kind of lived experience, that patient expert type services supporting patients across this system. So we're currently looking at what that might look like, and we're getting some views from patients on that. And we'll start to co-design that as we move forward. And then a rehab hub, which wouldn't necessarily be a standalone service, but is more about how do we come together as a range of services to make sure we're delivering really high quality rehabilitation, both before and after use of clinical services. And so what we actually see is that the initial business case, the initial investment was around small number of things that NHSC had suggested we needed, really, and quite high investment, but also high risk. And then where we're at now for this next phase will be an awful lot more in terms of those projects that are rolling out across the system we're actually trying to join up, but also that's less investment than we'd originally planned, and it's far lower risk because we've got far more people engaged with helping deliver this vision. And we hope that continues to grow. So summary of sort of what we're doing is we're kind of defining the boundaries of our system at the moment. We're starting to say who needs to be included in this, what does it look like, how can we make sure that they are the people informing the key decisions across this service. How do we then start to build social contracts and build those system relationships? What does it take to focus on trust and collaboration? Because there are lots of reasons why trust and those relationships break down across systems, and what do we need to do to actually overcome that and actually follow through with some of the commitments that we make to actually delivering for that, and that we put the patient at the center of every decision. So, and that genuinely means making sure that we include and involve patients with all of those tough decisions, even if they feel that they're removed and not specifically relevant for patients. We have to remember that every step of this, the impact of every decision falls on the patient, so we need to include them in that. And asking essentially what we can do better with what we currently have before we start to ask for more. So we're starting to think about how can we really start to redesign what we currently have and shape that and build those relationships to do what we do better before we start thinking about what we need in addition and adding more complexity to an already complex system. So that's a sort of brief whistle-stop tour of our presentation. There's obviously an awful lot more to what we're doing, and we're keen to engage as many people as possible in helping shape this. But hopefully that gives you a flavour of the direction of travel for Berkshire West ICP.
Great, Carl. Thank you very much. There's a lot there. One of the things I wanted to ask you, Carl, is I've been a consultant since 1996, so I've seen quite a lot of change. And one of the things I reflect on are the drivers for change in the NHS. And could you just say what was the driver for this change that you were involved with? And your experience of driving change, what are the main initial drivers?
I think there was a range of drivers, as is always the case. You've got the pressures that the NHS has generally around actually managing their own finances, but there was also some feedback that we weren't delivering services in the way that patients would expect. And I think what they took from in those early days was that we needed to engage and have a conversation around what that meant. And as those conversations built, that then started to become the driver for the further change that happened.
It's just that often it's political or financial. Putting it out there, that the biggest changes I've seen are usually political, it's financial. There are occasional changes when trusts merge, when you move hot cold, because that's the only way to help patients. But it's the sad part of the thing that as clinicians, it's very difficult to get change that you think clinically or with your patients, this is the way forward. So just a reflection on that. There are a couple of questions, but I'll take the chair's prerogative and ask another one. The other thing, I look around at the managers and the skill set of the managers who are often firefighting all day. So I often wonder, do they actually have the skill set within the NHS to manage and initiate change like this whole systems-wide approach, or do we really need all the external consultants that are often pilloried for the amount of money the NHS pays for?
Yeah, no, I think it's a really important question. I think we certainly have the skills. I think we certainly have the knowledge and the ideas and between the patient, clinician and managers to actually understand what change. As you've alluded to, it's getting the time and space often to be able to do this and getting those people in. And what we often do when we bring in external companies is we pay for the kind of facilitation, we create the time and space, and that's what yields the results. And I think we certainly can do that if we can remain committed to that kind of vision of let's drive this forward as a group and a partnership, rather than let's try and tackle one problem in isolation.
Well, that's what I was struck about Lynsey's story earlier on. Clearly, there was a willing group of individuals who recognized that something had to be done, and externality and that experience and professional skill set actually brought that about. So it's a really important area, one that's close to my heart, about thinking about change, lean thinking, and trying to bring people together. but I'm struck by how little training there is amongst clinicians to work like this, how we don't create capacity and experience for our managers to help us with this, and a culture of constant improvement.
It's just, if I could, Sanjeev, because that's essentially what I'm looking at from a PhD perspective, is why do we get stuck in what's called the productivity dilemma? Why do we get stuck with the firefighting and the day-to-day management of issues that actually, if we were allowed the time and space, we'd solve and not need to keep on that kind of treadmill of firefighting?
Well, you're absolutely correct, a treadmill. So I've got a couple of questions for you. So Ruth and Rachel have a question about using PROMs across the whole system. And can you give us examples of the PROMs and PREMS tools, please?
So obviously everything is just about starting, as I say. So these are really fresh off the press in terms of the ideas of what we're trying to look at. And we're in the process of now building and going to consultation on what that should look like. And that will be open for everybody to have their view. And what we don't want to do is dictate something that doesn't work for clinicians or patients. So it may be that if we can find ways to use multiple ones, but actually what we need to do is make sure that we get that information as part of the decision-making process across the system for strategic decisions.
Okay, great. And then one question from Anna Doran about, I'm curious what methods you intend to use to involve patients, or you've used to involve patients?
So as I said, so there was a huge engagement piece early on, just that was around general consultation around what does and doesn't work. And then what we've done recently is structure the program so that we have the patient reference group, and we've also had a patient leading some of the work and actually holding us to account through those groups.
Excellent. Well, I'm going to push on because I've got one more question.
Go on.
Interesting one. Have you reached out to pharma to identify how they could collaborate with you?
No, is the honest answer. We haven't, no. So it's something that probably will come out. And like I say, this will remain live and iterative, and we can start to build more and more partnerships over time with this.
Great. Well, look, I definitely think we need more of this type of work. And I just don't know how we create the space to do that. But without doing it, we'll be always on the treadmill.
Indeed.
Great. Thank you, Carl. That was excellent. So I'm going to move on to my colleague, Lynsey MacPhie. Lynsey and I work closely together. She's chair of the Clinical Affairs Committee at BSR. She's a consultant rheumatologist, and she works at the Lancashire and South Cumbrian NHS Foundation Trust. It's primarily based in the community. So I'm going to hand over to Lynsey to give us a final perspective on this really important area.
Thank you, Sanjeev. So hopefully I've not made the first mistake of being on mute. And hopefully you can see my slides. So as ever, a huge thank you to Sue and the team from ARMA for inviting me to share you with, if you like, our journey of how I've ended up as part of an integrated MSK service. And I'm very proud to be here and speaking on behalf of the whole service for the journey that we've been on. So just to give you a bit of a background as to what I'm going to cover in my 15 minutes, I'm going to give you a little bit of a history as to how we've ended up as the service that we have done, because I think that's really important. And it's also in quite stark contrast to the journey that both Lynsey and Carl have been on with their services. And also to talk to you about the tender process that we went through. And then really the crux of the talk is to talk about the positives of how we are working across the disciplines within our service to break down those barriers, which is the focus for this afternoon session. So in 2010, the rheumatology service in Preston moved out of the acute trust into a community setting. And this was actually after a failed tender process. So we didn't have any bidders for the service, which feels quite sad. I was just a mere registrar at the time with the service, but we moved into this fantastic long-term conditions centre, which had been commissioned by our PCT, and this was in the days of PCTs. And so we moved out under the provider arm of the PCT. So a slightly unusual setting, moved out into the community, and there was a lot of change happened, as you can imagine. And then a year down the line, there was the transforming community services. And what happened was all the provider community services moved into our mental health trust locally. So we became part of Lancashire Care Foundation Trust, which was predominantly a mental health trust. So it became very, slightly odd for us working alongside mostly consultant psychiatrists, but an interesting mix. And it soon became very apparent that there were lots and lots of different providers locally for MSK services. So we had a dedicated MSK service, which was headed up by Virgin, and we had a number of different physiotherapist providers, as well as the orthopaedic surgeons at the Acute Trust, a number of private providers who were doing orthopaedics work at a couple of local hospitals. So I think in total, we had 6 different care providers. So the CCG decided that the services for patients with MSK complaints were very fragmented and disjointed. Patient journeys were often lengthy and complicated. The right care data showed that there were a significant outlier with respect to elective spend on MSK, and this was a real worry for the CCG. There were huge gaps in provision and probably most importantly, a lack of integration across these services. So the CCG put forward a solution, and this was based on the 9 pillars. This is what we had to bid against. And it was a complete systemic redesign, enhancing partnership working across the disciplines. And to be honest, the biggest thing was a cultural change in the approach to MSK services. So they put out tender for an integrated MSK service, which was to include community MSK physiotherapy, the Tier 2 service, a new community pain service alongside the hospital's pain service, the rheumatology service, and also a dedicated CFSME service. Important to highlight is that orthopaedics were kept out of the CCG's tender process, and we did raise concerns about this, and I'll allude to this later. And just to highlight, those were the 9 pillars of which we had to build our bid. And particular ones I'm going to focus on is the importance of the single point of access, the service being clinically led, the emphasis on self-care and management, and also having a single integrated IT system. I'm not going to spend too much on this slide, but you can probably gather that the tender process was quite drawn out. We were up against 5 different bidders, 3 of which were private providers, and the whole process took 18 months. There was an awful lot of engagement on all fronts. There was opportunities for us to meet with the commissioners and have informal discussions. And then we went through a competitive dialogue session, which involved 3 individual days of full day interviews with the whole team. And it was expected that every bidder should have involved patients in their bid and involved them in the discussion with designing their service. And we also had patient representatives at each of our sessions and interviews on both sides. So on the panel judging the bids, as well as within our team. It all got rather complicated as there were 2 bidders which tied, so we had to have a tie-break interview, and then for various reasons that had to be rerun. So all in all, it was quite a drawn out, and I think it's fair to say, challenging and stressful 18 months. It was difficult to maintain the staff morale because there was a lot of nervousness as to who we were going to end up working for, but we did manage to hold on to the vast majority of our team in the rheumatology sector. So we won the bid, LSCFT, which was obviously great news, and we then set up a partnership board with our 2 CCGs, Greater Preston and Chorley and South Ribble. And our service is referred to as the Central Lancashire Moving Well Service. And our organisation is the prime provider, and we subcontract various elements to other providers. So our key subcontractor is Ascenti, who provide the MSK and the MSK physiotherapy elements. And as mentioned already, these are the disciplines across which we work, but we don't include orthopaedics. So what's different about our service? It's an integrated service. We also have our single point of access. There's a huge emphasis on empowering patients and involving patients in the model and the discussions about the model and how it's evolving further. We have a self-referral route for physiotherapy. We're very keen on shared decision-making, and I'm going to touch on this a little bit more. And there's also a huge emphasis on self-management. We run dedicated pain management and fibromyalgia programs, as well as the escape program within MSK. And probably what's slightly unusual, I suspect, is the opportunity for patients, once they've been discharged from any element of the service, to self-refer back into the service if they still have ongoing concerns with respect to the complaint which they were referred. And that open access remains in place for 12 months following discharge. And that's helped GPs tremendously with patients going back and asking if they can seek further advice. The other key thing for me is education. And I'm going to touch a little bit on how we come together as a service to share and learn and also improve the service further. But we've also got medical students, AHP students from all across the different disciplines are able to come and have some insight of how our service work. We do an awful lot of engagement with GPs and we've also done some public engagement. So the single point of access was one of the 9 pillars, and we have had some challenges with making this work. And if people out there know about the e-referral system, which is the national system for referring patients, there are some challenges if you set up a multidiscipline service. We've not been able to get round the fact locally we have to have separate triage streams for rheumatology, MSK, community pain and CFSME, and that's been a bit of a challenge. But because of the principle behind which our whole service is based, we have been able to work with the CCG to triage and to direct all of the referrals through, which normally would go through to orthopaedics, because it became very apparent early on that some patients were slipping, if you like, slipping around the net and diverting from our service and going straight to orthopaedics. So we managed to set the filters through ERS so that everything for orthopaedics and also for the hospital pain service would filter through our triage. So that's been really helpful for us to work collaboratively across and with the GPs and also with our secondary care providers. We've done a lot of work to provide clarity for referrers on what our service is all about and where it sits, particularly in relationship to the secondary care services for orthopaedics and the hospital pain service. But probably for me as a clinician, probably the most valuable thing that we've done is we have regular meetings of all the triages across all the disciplines. So that's the consultant rheumatologist and our ESP within the rheumatology team, with the APPs within our MSK service, and also within the physiotherapists who do the triage within the community pain and CFSME service. And we all meet every other month to just discuss the challenges that we're facing, the positives, and we've done a couple of really big audits where we've been able to identify patients that are maybe not getting the best pathway, and we've been able to change some of the processes around the triage. So one of the things that came out of one of the triage audits was that we had a number of duplicate referrals coming in, whereby GPs were maybe referring to 2 or 3 disciplines at the same time, which was alarming to say the least. So we've managed to put some systems in place to check for duplicates at the point of entry. We've also managed to have a look at the quality of referrals and have a see across the disciplines how many were being sent back, and then we've been able to work on how we improve the quality of referrals with the CCG. Interdisciplinary team working, I mean, Lynsey said an awful lot about this, but it's been really, really important for us to not just work within our teams, but to promote discussions between the teams within the service. There are over 90 clinicians working within our service, so we can't have one great big MDT meeting, it just doesn't work. But what we've done is utilise the EMIS IT record, which is our joint record across the service, so that people are encouraged to have discussions. So I often will get queries from the MSK clinicians about a patient who they're not too sure whether or not they need a rheumatology input. I will task my colleagues over in the community pain service if I've got a patient who I feel is appropriate. And we also have a lot of patients, particularly within the rheumatology setting, who benefit from the input of our community pain team. And again, we get able to keep those discussions live with the clinicians working across the different disciplines. So often our therapists in the pain service will let our nurses know that a patient's being seen by them and what their concerns are. So it's been a really good opportunity to work for the better for our patients, but also for us to learn from each other as well, because we've all got different strengths and we're all there to complement each other in the care that we provide for patients. To me, this is one of the things that I've been particularly proud of, and this is our clinical peer review. So this is where we all come together, all the clinicians, and we have these meetings quarterly to share and learn together. There's always opportunities for coffee and cake, but unfortunately in the world of virtual meetings now, for our last couple of meetings, that networking maybe hasn't been happening quite as much as it was doing when we all used to meet face to face, but they've still been happening. And we spend a particular focus on updating, and that's been particularly important during COVID, to update all of the service about what's been happening within the individual teams. And we also have sessions which are dedicated to learning from complaints and incidents that have happened and to share that learning more widely across the whole service. And then we've had educational components to each of our meetings, and usually this is a sort of fixed hour of learning, and each of the teams take it in turns to do some education which they feel is relevant to the whole service. So we had our occupational therapist within the CFSME service talk to us about some tips and strategies for managing fatigue, which was really appreciated. Our last session focused on the role of investigations, and we had one of our MSK APPs talk about the role of MSK investigations, and I delivered a session on understanding rheumatology bloods. But it's really great, and the clinicians really enjoy the learning across the whole team and the opportunity to ask questions. And we also try and incorporate case discussions of patients who've been seen by different teams within the service, and again, shouting about the benefits of us working as part of this integrated service. We were fortunate after a year up and running that we had a service away day, so this really allowed us to all step outside of our comfort zone. We were building dens, making fires, went on a wildlife hunt. But again, I think these are really important days for teams to bond, especially when you've got so many clinicians. And probably important to highlight is we work out of something like 22 different healthcare settings, as a lot of our physiotherapists are seeing patients over in GP surgeries, and also in health centres and gyms across the patch. GP education, because of our service being commissioned and because of the CCG and the tender process that we went through, I think it's been fair to say that the commissioners have very much welcomed us to have a voice at our GP education days. So we've had lots and lots of opportunities in the 2 years that we've been live to get out there and to deliver workshops at the GP formal education sessions. And we've really appreciated that opportunity from the CCG. Because we recognise that not every specialty has been able to have that support. But it's been great to make sure that GPs locally understand the service, as it is quite a complex service, and understand where it sits, again, with relation to orthopaedics and the pain hospital services. And then we've done a lot of work with the CCG medical advisors because of the close relationship that we've built through the tender process and the commissioning process to work on pathways. We've done a lot of work on making sure that reports on the bloods that get sent back to GPs make clinical sense. So we've managed to tweak some of the wording, particularly with regards to antibodies, which is a particular hot topic for rheumatologists. And we've now been able to design the prompts. So when GPs are requesting certain investigations, it gives them a little bit of clinical background that maybe don't test the antibody. If you're worried about a particular condition, just get on and refer them to your rheumatologist. And we're just about to launch a piece of work now to embed some prompts in the ICE system, which is what the GPs use to request investigations relevant to MSK investigations. So again, trying to encourage our GPs not to request lots of x-rays and scans, get on and refer them to the MSK service, and then we can decide if those are needed. There's been a little bit of talk today already about KPIs, but I think unfortunately KPIs can become rather a frustration as a clinician. And one of the things we've been able to do is to work very closely with our commissioners to make sure that those KPIs are clinically meaningful. So yes, how long patients are waiting to be seen is really important, but we need to make sure, and we've had to sort of work with our commissioners, especially during COVID, to understand the waiting times. But particularly important for me is that we've been able to talk to them about the triage time. So I think we had something like, when we started off, that 98% of referrals were meant to be triaged within 48 hours. And we've turned around and said, look, to have a good triage process, you need time. And sometimes we need to send referrals back. Sometimes we need to ask for more information. Sometimes we need to have a discussion within the team. So 98% being returned within 2 days is not giving us the opportunity as a service to really triage that referral to the high quality to make sure that that patient sees the right clinician first time. So we've been able to work with commissioners that we still aim for 2 days, but we've reduced the threshold on how many we have to meet. We've also managed to work with them to make sure that PROMs that we're collecting, so our initial KPI asked that an MSK HQ was done in every single patient coming into the service. And we helped them to understand that maybe if patients weren't going to have a sort of full treatment pathway with us, particularly pertinent for the MSK service, this maybe wasn't the best use of clinicians' time, because we'd never be able to measure it again if the patient just had an initial assessment and then was referred straight on to orthopaedics. So again, shaping KPIs, I think, is a really important thing to do with your CCG, and especially as a clinician, because then you feel what you're being asked for is relevant. Just a nod to shared decision making. There's been a lot of talk about shared decision making this morning, and it's music to my ears. We were fortunate to be shortlisted for one of the best practice awards from the BSR this year, and this is our poster, and you can go to the BSR website and find out more about what we did. But we're particularly proud of how we've embedded shared decision making within the service. And this was actually because of the forward thinking, really, of our commissioners to build a sequin into our service. So this was something that we had to provide evidence of, and evidence that everyone was trained and that we were doing it. So some of it was a bit of a tick box exercise on assessments to say, yes, this has happened. But then clinicians, we had to provide case reports, and we had to get feedback from patients using the Collaborate tool to really challenge, were we doing it? And what we did was we rolled out training delivered by our pain psychologist, who has a fantastic skill set and experience in delivering solution-focused consultations. And Emma went out to all of the individual teams and did a number of dedicated training sessions, getting the clinicians from each team to reflect and bring forward cases for further discussion. And that's how we've managed to embed shared decision-making within our service, something I'm really, really proud of as the clinical lead. This is a very busy slide, but this is our strategy slide for the next few years. Our trust asked for this, and basically it just emphasises some of the important things we want to work further on. Working with our partners, and particularly as part of the Integrated Care Partnership and our acute trust, working to promote advice and guidance, delivering other opportunities for which GPs can gain a secondary or specialist opinion from MSK, and also the emphasis on self-management, and including patients as partners is another key theme for us. So we recognise we've still got an awful lot of work to be done, and I've already mentioned the challenges that we face with orthopaedics not being part of the model. But one of the things that's happened with COVID, and this is a real positive for us, is that it's actually started to unblock some of the barriers that we just couldn't get orthopaedic support locally. But I think now, because of advice and guidance being rolled out in the way that it is being done, we're going to have an opportunity to work more closely with our orthopaedic surgeons locally, and that's really, really positive for us. We're looking at rotational posts across the four teams for our physiotherapists, and we've also got a couple of pilots launching with the first contact practitioners, and we're very keen that they're seen as part of the model and not a separate entity to the integrated MSK service. So we've got a lot of work to do with PCNs to help them to realise that. And then we're also looking at whether we extend advice and guidance as being a support mechanism between primary care and our service, but also for us seeking second opinions or additional opinions from specialists. So thank you ever so much. And really just a reminder, and this came up in the chat, it's not a one size fits all. We've evolved because of what history our service has been through, but it's a privilege to be heading up the service that I do. Thank you.
Well, Lizzie, that was amazing. I feel slightly breathless and fatigued by the amount of work and the achievement there. I'd like to summarize it by saying, you know, you've built, and with your colleagues have built, a fantastic team, and getting a high-performing team together is, I think, one of the greatest challenges I face as a clinician interested in this area and trying to break down boundaries and barriers. Now, I'm going to suggest that we have a couple of quick questions and quick answers, so I'm just going to quickly read them. Here's an interesting question from Paul Allen about the tender process. Sounds long and stressful, but at the same time seemed to help build innovation. And did you view it as positive or negative experience?
Anybody who knows me knows I'm a glass half full sort of person. So I have to say, I think we got to where we are very quickly because of the tender process, but it was incredibly stressful, and it needed a lot of strong teamwork to hold us all together, I'll be honest. But I think we have benefited from going through it because it made things happen very quickly, and we can now go back and say we have to have an integrated IT system, we have to involve patients because that's what you told us to do, and because it's written down in our bid, we have to do it. So I think the benefits outweigh the negatives.
Okay, great. I'm going to go 1 minute over, Sue, if that's all right. So here's a question about open access and patient-initiated follow-up. Can you tell us what your experience has been to date in a very few words?
Very positive. I think it really helps the GPs locally, but I think you've got to put some very firm safeguards around it for the patient's benefits as well. So I think certainly from our perspective, we have made sure that when a patient is discharged, there's very clear description within the letter and the correspondence to the patient, so that they understand when they can access the service, and also that it might be a phone call, it might not necessarily be another appointment, it might be a letter back to them. So I think safeguarding it and ring fencing it in the patient correspondence is really important.
Okay, now I'm conscious we have gone slightly over. So Sue, I'm going to close this session if that's all right. There are a couple of questions that I haven't asked, partly because they were slightly complex and would have taken longer to answer. But I'd like to ask everybody to thank the speakers. I thought they did a great job of defining the issue and giving us their personal experiences, most of which we can take away and think about and try and bring to our own practices. So thank you very much. And thank you, Sue.